Over the last probably 10, 15 years, there's been a whole shift away from a very biomedical model to much more of a biopsychosocial one, to really reflect that we have more and more evidence that really challenges the link between structure and pain. And because of that, it's really called into question some of our special tests. So I think when we look at assessment generally, one of the most important things is that 80% of our clinical decision making or diagnosis is based on our subjective assessment. So by the end of hearing somebody's story, I really should be pretty confident I know what the issue is and how that's going to impact my treatment. And then, if you like, my assessment is the 20% that confirms or negates that hypothesis. So when I look at my special tests, one, I think a lot of our special tests really aren't that special. And secondly, we need to ask ourselves the question, what are they trying to tell us? So if we look at a typical subacromial pain patient, and we look at a test like Hawkins-Kennedy impingement test or Neer impingement test, those tests really don't have any clinical utility because they tell us what we already know is that the shoulder hurts. But if we do those tests and it's painful, they don't tell us whether it's the bursa, the AC joint, the cuff. It really doesn't tell us anything different to somebody telling us they've got a painful arc. It hurts when they load it and it might hurt when they lie on it at night. So when we look at things like those pain provocation tests, I would agree they don't have any utility. However, the other big limitation of special test research is it generally takes a group of patients between 18 and 80 and applies the test. Well, if you don't have the subjective history, that special test is useless. Whereas if I use an example of somebody who's under the age of 25, they dislocate their shoulder, somebody has to put it back in joint for them, and they say they feel apprehensive. If I do an apprehension test and it's positive with all those factors, then they're 85, 90% likely to have a labral tear. So some of our special tests, our apprehension, our instability test, and some of our rotator cuff tests with a relevant history do have utility in guiding our clinical decision making, but they're a tiny part of the whole story.